Hello doctors. Today our topic of discussion is congenital abdominal wall defects. The congenital abdominal wall defects have mainly two main defects, that is omphalocele and gastrochisis. Before going into both these two defects in detail, first we will see few points about the embryology of development of the abdominal wall and gut. Now, the abdominal wall forms from the 4th week of gestation, like 1 month of gestation, the abdominal wall forms, and rapid growth of the intestine occurs in the 6th week. Because of the rapid growth of the intestine, there is physiological herniation of the bowel. Here we can see this is the physiological herniation, but this physiological herniation goes back into the abdominal cavity by 10th week. The midgut returns to abdominal cavity by 10th week. So this is the visceral mesogastrium and this is the parietal mesogastrium, and this goes inside by the 10th week. If there is failure of intestine to return to the abdominal cavity, this causes omphalocele. And what are the causes of gastrochisis? The causes of this are: number 1, failure of mesoderm to form in the midline. One is failure of mesoderm, another one is failure of lateral fold to fuse in the midline, which causes gastrochitis. Now there is another theory by De Vries and Hoyme which says that the thrombosis of right omphalomesenteric vein causes gastrochitis. So these things you have to remember. What is the cause of omphalocele and gastrochitis? Then starting with the gastrochitis, what is this? This is a congenital abdominal wall defect in which abdominal content, almost always intestine mainly, is eviscerated outside the abdominal cavity. Outside the abdominal cavity, as you can see in the picture, mostly this is the intestinal loop. No other organ generally comes out in gastrochitis. And why this happens? This is because failure of formation of mesoderm in the midline and fusion of lateral fold. Failure of fusion of lateral fold in the midline causes the gastrochitis. So you have to remember the incidence is 1 in 4,000 live birth. Diagnosed in USG prenatally by 20th week. When we do the USG, then we can see this abdominal loops, that is intestinal loops, are floating in the amniotic fluid, which is the suggestive of gastrochitis. And there is abnormal alpha fetoprotein, almost 7-fold increase in alpha fetoprotein is present. And generally raised alpha fetoprotein is present in any kind of abdominal wall defect. Now, preterm delivery is more common in this child, and concomitant bowel atresia. Remember this, 6.9 to 28%. This bowel which is protruding out, this might have atresia. And amniotic band syndrome is associated in gastrochisis. And generally in this, interleukin 6 and interleukin 8 are increased, and ferritin level are also elevated in this case. Remember this point. Now, how will you manage this case? The management is optimal mode of delivery, means we will do the vaginal delivery only until and unless any obstetric indication is present. Then we will do the cesarean section. Then we have to give IV access, RT insertion should be done, herniated bowel loop should be taken care of, and careful exploration of the bowel loop should be done, because there can be intestinal atresia with it, or malrotation of gut may be present, or necrosis or perforation of gut may be present in these patients. Another point is, which is very important, that is gastrochisis is associated with cryptorchidism in 15 to 30% of cases, and this you have to remember. Now the surgical management. The surgical management primary goal is to return the viscera safely in the abdominal cavity. Number 1, you have to return the viscera safely. Number 2, while inserting the viscera, you have to minimize the risk of trauma and minimize the risk of increase in intra-abdominal pressure. Intra-abdominal pressure, you have to manage that. There shouldn't be increase in intra-abdominal pressure, because intra-abdominal pressure rise will lead to abdominal compartment syndrome later on. And number 3 is to rule out associated bowel conditions. These are the primary goal. Now, what are the techniques? Techniques are: number 1 is silo placement. Silo is nothing but plastic bag. Plastic bag is used. Here we can see this is a silo placement. The intestinal loops which are protruding out are covered by a sterile plastic. This is known as silo placement, and serial reduction is done, because if we put the intestinal loop at once inside the abdominal cavity, then there will be increased in intra-abdominal pressure, and which will lead to the compartment syndrome. So therefore there will be serial reduction, delayed abdominal wall closure, and primary reduction with closure. Primary reduction may be facial closure can be done, and prosthetic options are also present, like dura can be used. Apart from that, porcine small intestinal mucosa, submucosa, can also be used for primary delayed reduction and closure. Now, what are the post-op care we have to take? Post-op, there may be abnormal intestinal motility, there might be malabsorption from the intestine, pulmonary hypoplasia may be present, and there might be increased raised abdominal pressure, and other condition may be associated, like intestinal atresia, necrosis of the intestine, perforation of the intestine. These can be associated in the post-op features of the neonate. Now, omphalocele. What is omphalocele? Omphalocele is a midline abdominal wall defect of variable size and typically characterized by herniation of intra-abdominal content through the base of the umbilicus in the membranous sac. So here we can see that in this picture, the loop which are present outside, intestinal loop along with the liver or stomach, whatever is, this intestinal loop is covered by a sac. This is covered by a sac. But in gastrochisis, as we have seen here, this is not covered by a sac. Another point to remember is gastrochisis is present generally right to the umbilicus. This is present right to the umbilicus. The defect is present right to the umbilicus. But in cases of omphalocele, the defect is present at umbilicus. And in gastrochisis, generally intestinal loops are protruding out. But in cases of omphalocele, intra-abdominal content like intestines, small intestines, then liver can also get protruded out from the abdominal defect. Now here the incidence is also 1 in 3000 to 4000 live birth. But you have to remember this very importantly, that omphalocele is associated with chromosomal abnormality in 20% of cases, cardiac abnormality in 45% of cases, and congenital anomaly in 50% of cases. Therefore, because of these associations, the prognosis of omphalocele is poorer than the gastrochisis. Gastrochisis have better prognosis than omphalocele. And what are the congenital anomaly? Congenital anomaly like pentalogy of Cantrell may be associated with it. Like pentalogy of Cantrell, these are asked many times in NEETSS MCQ. What are the component of pentalogy of Cantrell? Number 1 is omphalocele, as we are reading. Number 2 is sternal cleft. Sternal cleft we have already read in the thoracic wall defects, part 2 of thoracic wall defect, sternal cleft. Number 3 is congenital diaphragmatic hernia, which is also covered. And number 4 is ectopia cordis, this is also covered. And number 5 is pericardial defects. These are the 5 components of the pentalogy of Cantrell. I am repeating once again for you. Number 1 is omphalocele. Number 2 is sternal cleft. Number 3 is congenital diaphragmatic hernia. Number 4 is ectopia cordis, and number 5 is pericardial defect. So this is pentalogy of Cantrell associated with omphalocele. Another is OEIS syndrome, that is omphalocele, extropy, imperforate anus, and spinal defect. Apart from that, it can be associated with Beckwith-Wiedemann syndrome, which is Beckwith-Wiedemann syndrome, which is omphalocele, which is associated with Wilms tumor. And other associated anomalies may also be present. These 2 are the very important. Now, management of omphalocele. Omphalocele, first you have to evaluate the any other chromosomal abnormality or congenital abnormality is present or not. As you know, cardiac cases is associated in 45% of cases. So 2D echo should be done to rule out VSD, that is ventricular septal defect, or ASD, that is atrial septal defect, or TOF, that is tetralogy of Fallot. Surgery should be staged closure. Skin flap cover can be done. Siloplastic can also be used, which I have already told previously. Then another important thing which is done here is escharotic therapy, that is thickening of sac. The escharotic therapy, generally the loops which are herniating out are covered by a sac in omphalocele, and when we put escharotic therapy, that is iodine or silver sulfadiazine or mercurochrome, then these causes thickening of the sac, and this thickening of the sac protects the bowel loops that are inside the sac. So this is known as escharotic therapy. Now 25% of these omphalocele condition after operation will be associated with wound and facial dehiscence in 25% of cases, and overall complication is seen in 12% of cases. So what do you mean by small omphalocele and large omphalocele? Small omphalocele means when the defect is less than 5 cm, and large omphalocele is when the defect is more than 5 cm. Small omphalocele generally recover well, and 43% of small omphalocele later on will have features of GERD, and 20% will have long-term respiratory complaints. So these are the important points on gastrochisis and omphalocele. Congenital abdominal wall defect. We will continue with the next chapter of the pediatric surgery. Thank you for watching, guys. Please do like, share and subscribe so that I can make more free videos for all the medical students. Thank you.